My topic for today is iodine MIBG imaging and therapy in neuroblastoma. I have nothing to disclose. This will be the outline of my topic. I will be introducing what is MIBG and how we image and what are the theranostic options in neuroblastoma and the response criteria and the take-home message. So what is MIBG? MIBG is a synthetic guanethidine analog of norepinephrine, and it is an aralkyl guanidine resulting from combination of benzyl group of beryllium and guanidine group of guanethidine, which is an adrenergic neuron blocker. MIBG also holds the ability to target tumors irrespective of their MIC status or specific histology. So there was this first publication in 1980 on MIBG for adrenal medulla, which was first published by the people at University of Michigan. However, the FDA approved iodine 123 MIBG for diagnostics in 2008 and for theranostics for therapy in 2018 with iodine 131. What is a mechanism of MIBG uptake? So this uptake involves an active uptake one mechanism and a passive diffusion process. In neuroblastoma, MIBG is stored within cytoplasm and is predominantly extravesicular. So as we know, neuroblastoma is the most common extracranial solid tumor of childhood. Over 90% express norepinephrine transporter. This enables the application of meta-iodobenzyl guanidine, which is MIBG for neuroblastoma. So what are the indications for radionuclide imaging in neuroblastoma? First is to confirm any suspected neuroectodermally derived tumors, which includes neuroblastoma, pheochromocytoma, and ganglioneuroma. And also for staging of disease, therapy planning and assessment of response, follow-up after treatment, and before planning radionuclide therapy. So MIBG has shown high sensitivity and specificity. This is also recommended by the International Neuroblastoma Risk Group for evaluation of bone and bone marrow disease at initial staging and follow-up. So this is the normal distribution of an MIBG scan. It shows physiological uptake in the salivary gland, nasopharynx, nasal mucosa, myocardium, liver, and adrenals. MIBG is excreted via the renal system, so the bladder is also seen, and sometimes the bowel can also be seen, especially in the colon. So what is the radiation burden of MIBG radioiodine? It always depends on administered activity. So we have SPECT-CT also, which is useful for characterization of small retroperitoneal foci because sites of pathologic activity and physiologic activity are both common in the retroperitoneum. MIBG uptake in the skeleton is never normal and reflects involvement of bone marrow or bone by disease. So what are the different iodine that can be labeled with MIBG? The first is iodine 123. It is most suited for imaging due to short half-life of 13 hours. It has a gamma emission of 159 keV, and it is ideal for imaging with a gamma camera. It is cyclotron produced and not widely available, and we do not use it in our country. Iodine 131 is used both for imaging and therapy. It has a half-life of 8.02 days. It has both gamma and beta emission. The gamma emission is used for imaging and the beta emission for therapy. This is nuclear reactor produced, and this is what is routinely used across our nation. So how do you prepare the patient? We must take into account that there are several drugs that interfere with uptake and or retention of MIBG. And thyroid blockade is mandatory to prevent thyroid uptake of free radioactive iodine that has dissociated from the MIBG molecule. The dose for diagnostic imaging is about 0.5 to 2 millicurie of iodine 131 or 5 to 10 millicurie of iodine 123 MIBG. The route is always IV, intravenous. given slowly over 1 to 5 minutes to avoid side effects like hypertensive crisis or tachycardia. And the imaging is done after 24, 48, and 72 hours. So let's look at one of the diagnostic image of a child who was diagnosed to have neuroblastoma in 2016, underwent extensive treatment, and the diagnostic scan in August 2018 shows a retroperitoneal mass, which is very avid on MIBG. On follow-up, you can see that there are several other lesions which has taken up, including the skeletal lesions. This child, after extensive treatment, succumbed to her disease. What is MIBG scoring system? There are two scoring systems for MIBG scintigraphy. The Curie score, which consists of 9 osteomedullary segments and a 10th soft tissue segment, and the Ciopen score, that is the International Society of Paediatric Oncology Europe Neuroblastoma group, which consists of 12 osteomedullary segments. So the Curie scoring system, each segment is graded as 0 with no involvement, 1 and 2 with 1 and 2 or more distinct lesions, and 3 with more than 50% of involvement. Several validation studies have been done, and post-induction Curie score of more than 2 is being associated with poor event-free survival. The Ciopen scoring system, which divides a skeleton into 12 segments, there is no segment for soft tissue involvement in the Ciopen scoring, unlike the Curie scoring. Again, these segments are graded as has been depicted on the slide. The post-induction skeletal score of more than 3 allows the identification of a very poor prognosis patient group requiring altered treatment strategies. And the bulk of MIBG avid skeletal metastatic disease at diagnosis, estimated with validated scoring systems of both Ciopen and Curie, has prognostic value. A Ciopen score of less than 3 and a Curie score of less than 2 carry a better prognosis than a score of more than 3 and 2, respectively. So what is theranostics, where nuclear medicine is involved in? It is a precision medicine which integrates both diagnostic nuclear medicine and radionuclide therapy. Simple dictum: see what you treat and treat what you see at a molecular level. So coming to MIBG therapy, once the MIBG scan is positive, then the patients are amenable for MIBG therapy. So over the past 35 years, MIBG therapy has been studied in more than 1,500 patients with high-risk neuroblastoma. Initially, research was focused on iodine 131 MIBG therapy as a salvage option in patients who failed first-line treatment. So how is it given? MIBG, as we know, the indications are if there is MIBG avidity, and if the lesions are unresectable, and also in locally advanced metastatic neuroblastoma. About 1 to 2 millicurie per kg slow IV infusion over 4 hours, that is 25 millicurie per hour, is administered. And what are the outcomes that we expect? Outcomes of symptomatic relief, which happens in approximately 75% of cases, partial radiological response in at least 30% of cases with relatively limited side effects. The main therapeutic goals are disease stabilization and symptom control. Thyroid blockade with stable iodide is mandatory. It can be used as first-line MIBG therapy upfront or as an induction and consolidation therapy. Few studies have shown the use of MIBG as induction therapy, where MIBG has been used as first line of treatment in even in newly diagnosed patients. MIBG has also been given in conjunction with myeloablative chemotherapy after response with initial chemotherapy consolidation therapy. In the second line, 3 types of treatment failure in neuroblastoma can be identified, such as refractory disease, progression of the disease, or relapse. So the response rates of MIBG vary widely in different studies. So a systematic review has quoted median response rates of 30% in relapsed and refractory neuroblastoma. So what are the toxicity of iodine 131 MIBG therapy? It can be characterized by time of onset relative to treatment and also the dose that has been given to the patient. When we are looking at a mild anti-tumor efficacy, it is given at a dose of 2 millicurie per kg. And when you're looking at significant marrow suppression, about 6 to 15 millicurie is being given. And if it is talking about marrow ablation, 18 to 24 millicurie per kg body weight has been administered. So the early toxicity can be in the form of nausea, emesis, hypertension, or parotitis. The intermediate can be myelosuppression, transfusions, which will require transfusion and stem cell support. And the late over a month or several months can lead to hypothyroidism, MDS, or AM. So let's look at one of the case of a child who was 2 years old, incidentally detected with an abdominal mass in August 2017, biopsy-proven neuroblastoma, bone marrow and urinary metanephritis were within normal limits. She also underwent rapid Kojak chemotherapy and TVD chemotherapy. This was her first diagnostic scan, which showed a significant retroperitoneal mass, and she was administered MIBG therapy. And following this, she was followed up every 6 months, and she has received at least 3 doses of MIBG therapy. This child is doing well. The last scan was done in 2021, and her last follow-up was in May 2025. Another child who was a 4-year-old child with ganglioneuroblastoma of the abdomen and received chemotherapy. And this child also underwent an FDG PET. Now, why do I talk about FDG PET when we are talking about MIBG? I'll come to it. This child showed a huge retroperitoneal mass. And on MIBG, we saw that there was a MIBG avid mass in the abdomen. She received 3 treatments again, and her last follow-up diagnostic scan was in March 2022. You can see that the intensity of the lesion has significantly reduced, and this child also is doing well with the last follow-up being April 2025. So what is the role of FDG, that is fluorodeoxyglucose PET-CT, in neuroblastoma? First, as a replacement of iodine MIBG in evaluation of MIBG negative or weakly MIBG positive neuroblastoma. Secondly, as a complementary modality when radiological imaging or clinical findings suggest more extensive disease than is revealed by iodine MIBG imaging. Fluorodeoxyglucose PET has taken over the role of technetium 99M MDP bone scan scintigraphy, which has long been second-line imaging to assess bone metastasis in MIBG negative tumors or in case of solitary equivocal MIBG bone uptake. So coming to the revised international neuroblastoma response criteria, the aim of this criteria was to remove less sensitive and less specific modalities for tumor assessment in neuroblastomas, such as MDP bone scans and catecholamine levels, and replace these with nuclear medicine studies such as MIBG and fluorodeoxyglucose PET-CT, which are more sensitive for detecting viable neuroblastoma and ganglioneuroblastoma. Functional imaging is the cornerstone of these revised criteria for neuroblastoma response, and loss of MIBG awareness may mimic complete response, whereas it is not complete response. As we look at this image, you can see a false complete response after iodine 131 MIBG therapy. And this, if you see the PET scan, we can see that certainly these children had significant disease, which was much better than expected. A post-therapy PET scan was requested, which showing non-MIBG avid progressive disease. So this is the new international neuroblastoma response criteria in terms of assessment of response. As we can see, there is a complete, partial, minor, stable, and progressive disease. So I will just sum it up, say for take-home message. Iodine 131 MIBG is a sensitive and simple option for neuroblastoma. It gives an additional and valuable tool to diagnose and treat neuroblastoma. Although there is abundant literature on MIBG therapy, heterogeneity of patients and schedules make it difficult to assess its true effectiveness. Prospective randomized controlled trials are essential to strengthen the evidence base on the use of iodine 131 MIBG therapy in patients with newly diagnosed high-risk neuroblastoma. Every complete response should be confirmed by another method, another functional scan such as PET scan to detect awareness loss. So targeted radionuclide therapy should preferably be performed at specialized centers with an experienced interdisciplinary team. Thank you for your patient hearing.